Welcome to this talk. This presentation is part of a larger program on building capacity in implementation science research and practice in low and middle income countries. This project is funded by a grant from the National Institute of Mental Health, which is part of the U.S. National Institutes of Health. These presentations on implementation science and measurement are specific to working in areas with few health resources. If you have more questions, you can find more information on our group's website, including more information specifically about this study. We hope you find this work useful.
Thank you for joining our webinar today on measurement of implementation outcomes in low and middle income countries. My name is Laura Murray. I'm on faculty at the Johns Hopkins Bloomberg School of Public Health in the Department of Mental Health. I'm a clinical psychologist by training and have been doing implementation studies since my postdoc years. I'll be presenting today alongside my colleague, Dr. Emily Harrows.
Thanks, Laura, and really glad to be here with all of you. I'm an assistant scientist in the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health as well, and I focus on research methods for implementation science in low-resource and global contexts.
So here we have an applied mental health research group, a multidisciplinary group that focuses on mental and behavioral health in low and middle income countries. We do a number of tasks such as qualitative ethnographic work, validation of instruments, randomized clinical trials, and implementation research all over the world. For example, in Iraq, Cambodia, Zambia, Myanmar, and many other places. These projects span a range of topics, such as gender-based violence or violence in general, child sexual abuse and HIV, internally displaced persons and veterans, victims of torture or political violence, and on and on. Please take a look at our webpage to understand more about the breadth and depth of our projects. For today's webinar, we will be talking about measurement of implementation outcomes in low and middle income countries. We hope that some of you were able to see the first part of this webinar series that introduced implementation science in global mental health. These webinars are funded through a National Institute of Mental Health research project our team is currently running on implementation science in Myanmar, with a focus on capacity building. We will talk a bit more about this project towards the end of this presentation as an example of how we are using the implementation science measurement in it. So as I said, we presented a webinar on the basics of implementation science. This webinar today is a follow-up to that and will focus on how we measure important constructs within implementation science. Here is a brief outline of what we will be reviewing: the background and what constructs we will be looking at, existing measures from high-income countries, challenges with measurement. Then we will move into measurement within low and middle income countries and how we developed a measure. Finally, we'll talk about the use of this measure and next steps. So let's begin with a background. Despite robust evidence on the benefits of many healthcare programs in low and middle income countries, there is a significant gap between what is found to be effective and what is done in actual practice. Over the past 20 years, the researchers in global mental health have repeatedly demonstrated the effectiveness of services to treat mental health problems in low and middle income countries. Despite this progress, wide scale-up and sustainability of such evidence-based programs is virtually non-existent. The field of implementation science has coalesced over how to bridge this gap. However, there are significant gaps related to measurement issues that are critical to advancing implementation science efforts. Without high-quality measurement, it is impossible to study the process of implementation and the effect of implementation strategies for mental health in low and middle income settings. Our Applied Mental Health Research Group has spent the last 20 years pushing to understand and develop ways to measure mental health symptoms and syndromes in a wide array of low and middle income country settings. We set out to use that experience and apply it to measurement of implementation outcomes across a diverse range of settings. There are many different frameworks within implementation science. some that we touched on during our first webinar. Here, we will review the framework that we focused on that are most relevant to global mental health. One that we began with is Dr. Enola Proctor's. And here you see the implementation outcomes. We will talk more about these as this webinar goes on. Here is a closer look at the definitions of some of the outcomes we began focusing on. You see here how the field is trying to operationalize these outcomes. These definitions are critical because they guide items that would measure each of these constructs. So, for example, you see here adoption is operationalized as the intention, initial decision, or action to try or employ an innovation or evidence-based practice. We will talk more about how we further operationalized each of these constructs for low and middle income countries, but we wanted to give you all a sense of what outcomes we were talking about. Here we highlight 2 recent reviews published on the measurement of implementation science and the number of instruments they identified. You see here 104 and 130. There are many, many instruments out there. It is evident that even within the United States and other high-income countries, there is a significant amount of work being done on reviewing and trying to harmonize measurement within implementation science. Part of what we wanted to do in this webinar is give you some resources. These are resources that are available regarding measurement within implementation science. This Grid-Enabled Measures, or GEM, portal was created by the National Cancer Institute to support behavioral and social scientists and other stakeholders as they advance their research and clinical practice. Here is just a shot of their website. GEM is an incredible resource. It includes existing measures, their use, psychometrics, if they're available. You see here that they have uploaded measures and they have many, many people downloading them. Another resource we wanted to share with all of you is the SIRC Instrument Review Project. SIRC standing for Society for Implementation Research Collaboration. They have spent many years reviewing and synthesizing instruments that evaluate dissemination and implementation research constructs. Here we have a web link for you and encourage you to check this out. Here we wanted to show you an example of what you will see if you move further through the SIRC instrument website. These are all examples of the many different measures that solely look at implementation climate. So they define implementation climate as the absorptive capacity for change, shared receptivity of involved individuals to an intervention, and the extent to which use of that intervention will be rewarded, supported, and expected within their organization. Now, I don't want you to feel like you have to digest all of this data on your screen right now. Our main point in showing you this is so that you see an example of the great work SIRC has done to consolidate data and research in a way that is helpful in understanding and learning about measurement of dissemination and implementation research constructs. Something like this could help you know what measures exist and the psychometrics behind them that would help you make choices with what instruments you may choose for your study or project. Despite the vast number of measures that are out there, there are many challenges with how to assess implementation processes and outcomes. These are well documented in the literature now, with these really existing in the field overall. Major challenges include varying definitions of outcomes across frameworks. For example, leadership might be defined as specific to leading an implementation effort or be more general about characteristics of leaders. Second, most studies often use their own measures or indicators, meaning there is little overlap between projects. Third, many measures focus on only one construct. For example, an entire measure only on leadership, or an entire measure only on organizational culture, and almost all focus on only one stakeholder level. Stakeholder levels play a role in implementation, and it's really important to look across all of those levels. Fourth, Many measures are quite long. For example, the organizational readiness for change measures over 100 items and still looks at only one construct. So what happens with long measures? Well, participants and respondents often get very tired and fatigued. They may answer incorrectly, and it's often challenging for programs to implement. Fifth, there has been very little rigorous testing of measures. So how do we know if they're really valid or really measuring what we think they're measuring? Are they reliable measures? Or in other words, are your results on measures consistent over time? Finally, with different items, definitions, and domains, it is very hard to pool data across studies, which makes synthesis across studies challenging. And this is an important way to move fields forward. So in global mental health specifically, we face even more challenges. When we started this process in 2011, there were no existing implementation measures that had been studied in low and middle income countries. Most of our participants have never been exposed to mental health services. This is often true at the organization, provider, and consumer level. Task shifting, or the use of lay or non-specialist counselors, means that few have been exposed to other ways to implement mental health services. This makes it challenging for assessment, as without exposure to variation in implementation, it is very hard for them to judge the degree to which a program is well implemented. One of our biggest challenges is that the field of implementation science has largely been based in Western contexts where mental health systems are in place. However, we are often working in places where these systems don't exist. So, for example, there are no centers that offer mental health services. There are no social workers, psychologists, or psychiatrists. Finally, many of the items on existing measures are irrelevant to lower resource settings. For example, items related to ongoing educational credits, professional organizations, and insurance reimbursements and billing often don't relate to the settings we work in.
So measurement is fundamental to science. It has been quoted that science is measurement. Without careful attention to measurement and implementation science in global mental health, what we risk doing is akin to building a magnificent house without a solid foundation. The science will collapse if our measures are not solid. So now we want to focus on measurement in low and middle income countries.
So when we started this, we decided that an important first step was to try to adapt existing measures from high-income countries and evaluate their use in low and middle income settings. We decided on 3 measurements that assessed constructs that we were interested in and had some good psychometrics. So you see here, we used the dimensions of organizational readiness, the organizational readiness for change, and the evidence-based practiced attitude scale. We did this in Iraq, Zambia, and the Thailand-Myanmar border. Our psychometric results from these studies were very mixed. The measures did not work very well across multiple stakeholder levels, and we found that many items didn't cross over to these low and middle income settings. We also received feedback that the instruments were very long. As a group, we found ourselves wanting more constructs evaluated across multiple stakeholder levels to get a better picture of what was actually happening.
Given our pretty clear results that taking Western measures didn't work as well as we had hoped, we decided to try again. For the second attempt, we decided we would develop our own measure that would be specific to the context of low and middle income countries. To do this, we used 7 steps, beginning with a strong focus on our outcome definitions, through ultimate development, piloting, and finally testing of our instruments. To start, we went back to the definitions. However, when we focused on these, we decided we needed to operationalize them further for the context we are working in. For example, as Laura mentioned, adoption was defined as the intention, initial decision, or action to try or employ an innovation or evidence-based practice. We added the engagement or disengagement with the innovation through implementation. We thought that adoption is not always an initial decision, but rather a decision to continually engage in the program. For feasibility, it was previously defined as the extent to which a new program or policy can be successfully used or carried out within a given agency, in a particular setting, or in a certain population. We thought this was too theoretical, so we tried to add more specifics, as in it takes personnel, money, time, buildings, and furniture. As Laura has mentioned throughout this webinar, multiple stakeholder levels is important to implementation science. When we talk about this, we are defining a consumer as a person who is receiving a service, a provider, a person who is directly providing the service to the consumer. An organization is the local organization that directly manages the provider, and the government or policy level are the participants that have overarching responsibility for multiple local organizations. We believe that all of these types of stakeholders play a key role in implementation of programs, so it was important to be able to measure implementation outcomes from each perspective. After defining our outcomes, we returned to the major theoretical frameworks to help us in better understanding the process of implementation and the components that go into implementation of programs. With the Proctor model guiding our outcomes and definitions, we also consulted the Consolidated Framework for Implementation Research, the REAIM framework, Reach, Effectiveness, Adoption, Implementation, and Maintenance, and the EPIS framework, Exploration, Preparation, Implementation, and Sustainment. These frameworks helped us in fleshing out the content of each outcome. Using these theoretical frameworks, we mapped the constructs that were delineated in each framework to our outcomes. For example, in our acceptability outcome, we grouped constructs from the CFIR and EPIS framework. In CFIR, they talk about the compatibility of the intervention or the relative priority of the intervention. Both of these concepts we grouped under our acceptability outcome. This process helped us in thinking through what constructs would need to be covered under each outcome. Finally, we use log frames to help us in linking together our constructs and ultimately developing indicators for these constructs. For example, the constructs from the theoretical frameworks were grouped under intermediate results. We then generated specific indicators to act as the measures for these intermediate results. This also helped us better lay out where we would obtain the data for each indicator. We repeated this process for each outcome and for all stakeholder levels. Ultimately, we ended up with a log frame for acceptability for consumers, providers, organizations, and policy, a log frame for adoption for consumers, providers, organizations, and policymakers, and so on. The indicators we specified in the log frames became our items in our draft instruments. Here is an example of the acceptability scale.
That's right, Emily. And so in the process of developing an instrument for implementation in low and middle income countries, where there were no or very limited services, we also wanted to include a step of expert review. We consulted with several implementation science experts to determine whether we were missing any major domains or questions. In addition to our Applied Mental Health Research Group, experts in low and middle income countries, for example, Dr. Vita Toll and William Weiss, who have been doing global work in low and middle income countries for over a decade. We also consulted with mental health experts who do implementation research in both high-income countries and low and middle income countries. For example, Dr. Helena Verdelli. And also with implementation research experts such as Dr. Ross Bronson and multiple fellows from the IRI. Several questions, particularly related to organizational culture and climate, were added to the draft questionnaires.
Thanks so much, Laura. So after all that formative work, we then pilot tested the draft instruments in Myanmar and northern Iraq and Kurdistan. We conducted quantitative survey interviews with consumers, providers, organizational level directors and staff, and people involved in policymaking. We also conducted semi-structured interviews with these stakeholders as well. Here's a more specific breakdown of the number of participants that we interviewed. As you can see, we had the most number of participants at the consumer level, with sample sizes getting smaller for different levels of stakeholders. Of particular note is our very low sample sizes for organizational level in Myanmar and policy level in both sites. These sample sizes prohibited any quantitative data analysis, so I will only discuss the qualitative results from those levels. So let's back up quickly to give you a frame of reference. For those of you who are not as familiar with statistics, one very coarse measure of how well scales are performing is the Cronbach's alpha. This basically just tells us if the items in a scale seem to hang together well. In other words, do all the items in the scale seem to be measuring the same thing? This is by no means a comprehensive measure of a scale's performance, but for a pilot study, it at least tells us if the items on our scale seem to be cohesive and consistent. Generally, when we look at alphas, we're looking for a value above 0.7 to be considered acceptable. As you can see from the consumer results, many of our scales did not perform that well. For example, our smallest alpha was for the feasibility scale at baseline. Our highest alpha only reached 0.8 for the penetration or accessibility scales. Now let's look at the provider level. At the provider level, we got slightly better results, particularly in Myanmar. But again, you see a wide range in alpha levels, suggesting major revisions to the scales for providers were warranted. Finally, at the organizational level in Kurdistan, we again see these wide range, from 0.36 for willingness to change to 0.89 for autonomy at the follow-up time point. This all suggests that more work needs to be done. As for the qualitative results, participants in Myanmar pointed out several facilitators to well-implemented programs. Consumers found that the counselors were flexible and willing to adjust schedules to fit clients' needs. They liked that the counseling relieved their problematic feelings and helped them to overcome problems. They found that CETA was suitable for the culture in Myanmar. Among providers felt like the CETA program is effective. They reported positive relationships between themselves and their supervisors, and they found it useful that they share similar backgrounds with their clients. At the organizational staff level, participants discussed the fit of counseling with local values, and that as people became more aware of the program, its acceptance seemed to be increasing. At the policy level, participants again discussed that counseling services seemed to fit a need in the population. In terms of barriers to implementation in Myanmar, consumers spoke of a lack of awareness of the program, stigma and logistical issues including lack of time and money to get to services. Providers talked about logistical issues with finding private spaces, and reliance on donor support for the program to pay them. Organizational personnel also worried about funding and lack of government support for the program. While at the policy level, concerns related to the limited nature of the program in its current form, which was only in one language and was mostly delivered to a certain population. In Iraq, at the consumer level, facilitators included a fit with local values and the needs of the population. Consumers reported that they had good and trusting relationship with the counselor, and that flexible timing and scheduling was important. Provider and organizational levels, a positive work environment was the most frequently mentioned facilitator, along with the counselor feeling good about providing the services. At the consumer level, barriers included struggling with logistics, low awareness and stigma in the community, and not feeling comfortable with the counselor. At the provider and organizational levels, logistical challenges were problematic, lack of government support was seen as particularly challenging, and stigma and shame emerged as issues for both providers and organization. Looking across both sites and all stakeholder levels, major facilitators of well-implemented programs included having flexible schedules, positive relationships with the counselors, the fit of the service with local values and needs, and the importance of the counselor and supervisor relationship. Barriers included problems with logistics, low awareness and stigma, the duration of treatment, lack of government support, lack of sustained funding, and problems with securing private space. We used this qualitative data to find areas and items that we needed to include for mental health programming in LMIC. In other words, These are things that were important to the population, that affected their views of the program, and we wanted to make sure we captured this in future iterations of the instruments. Given the poor quantitative performance and issues that emerged from the qualitative study, we revised our measure. To revise the measure, we retained any well-performing items from pilot testing. We developed more items based on the qualitative study. We reworded items so that they were more neutral. So instead of saying, "I like providing the program," we said, "Do you like providing the program?" We also removed any reference to a specific program to allow these to be customizable to different settings. And finally, based on some of the qualitative data and newer literature in dissemination and implementation, we added and adapted scales on leadership and capacity for sustainability. So our final measure for testing includes scales on acceptability, adoption, appropriateness, feasibility, reach, capacity for sustainability, organizational culture, and leadership. The final step in our process was to test the measures. But how do you test them? As Laura brought up, we are often working in settings where most people we work with across stakeholder levels are unfamiliar with a variety of mental health programs. How then do we know if our instruments are capturing different levels of implementation, if respondents do not have experience with different levels of implementation? To overcome this challenge, we used a vignette method, in which we presented a hypothetical situation to participants for them to respond to. As part of our ongoing work in Ukraine, we administered our implementation measures to potential consumers of mental health programs. All of our participants were either internally displaced persons or veterans of the Ukrainian military. We also tested our provider measure among a sample of 151 providers through an online survey. Most of these providers were school-based psychologists, clinical psychologists, psychiatrists, and social workers. For the study, we developed 2 vignettes. One described existing psychiatric care in Ukraine, which was widely considered to be problematic. The other depicted a community-based psychotherapy program. We then randomly selected half of our participants to receive the psychiatric vignette and the other half of the participants to receive the psychotherapy vignette. Finally, we also asked participants to rate the program depicted in the vignette overall by providing them with a definition of the outcome and asking them to say how well the program in the vignette met that definition. For example, we provided them with a definition of acceptable as being a program that is satisfying and agreeable. We then asked participants to rate the program in the vignette on how much do they think the program described in the vignette meets that definition of acceptable. Our hypothesis was that a well-implemented psychotherapy program will be more likely to be adopted and viewed as acceptable, appropriate, feasible, and accessible compared to the psychiatric care by potential consumers and providers in Ukraine. Basically, what this means is that we hope to see higher scores for the people that read and responded to Vignette 2 than the participants who read and responded to Vignette 1. We also expected that higher scores on the scales would be associated with higher overall ratings for each of the specific outcomes. In general, results for both consumers and providers indicated good reliability and validity. These are the consumer results. I'm going to walk us through these graphs. The first shows average scores on each outcome scale by vignette. Again, for our hypothesis, what we wanted to see were significantly lower scores for those who rated the psychiatric vignette, the green bars, than for the vignette depicting the community-based psychotherapy intervention, the blue bars. In this graph, you see that ratings were universally higher for the psychotherapy vignette compared to the psychiatric vignette. Now, when you look at the second graph, this is comparing average scores on each scale by the overall ratings of whether the program depicted in the vignette met the definition for an adoptable, acceptable, appropriate, feasible, and accessible program. Again, we see here that scores on each scale were significantly higher for those that rated the program highly on these outcomes compared to those that rated them lower. These results show that our measure can capture some variation in implementation quality and supports their validity in this context. Analysis of our provider survey is ongoing, but preliminary analysis suggests similar results.
So Emily just walked through a lot of research and data. Now we're going to talk about the actual use of this measure and some next steps. So now that you've heard about the development and some testing over the years of a measure, looking at implementation research specifically within low and middle income countries, you might wonder, well, gosh, how would we actually use this measure? Well, when using a measure in any new context, it is always best to test before use, if possible. We are really excited about ongoing testing of the instrument by our group, along with many others, but additional testing is always needed and helpful. Another question we often get related to use is when to use them: pre-implementation, during implementation, post-implementation. In high-income countries, implementation measures may be given pre- and post-implementation. We have found the pre-implementation time point challenging in low and middle income settings because often there is no context or understanding of a mental health system, as we've mentioned before. So answering these questions is very difficult. Post-implementation or multiple time points within implementation are both possible ways to use this measure. This would allow you to look at changes over time. For example, change in acceptability of an intervention right after they were trained in it versus after they've used it for a few months.
For scoring these scales, we recommend taking the average of the items in each subscale to generate a scale level score. We have also used individual items with low average scores across participants to be indicators of areas for further improvement. Here, we also list some purposes of using the instrument. We believe this measure has been helpful in informing implementation, identifying barriers and facilitators to implementation, and informing strategies needed to improve implementation. Finally, measuring the effects of implementation strategies, such as how feasible is it to use a lay provider? Is a program more likely to be sustained with additional organizational support? Is another way you could use this measure.
So our team has a number of ongoing studies using this implementation measure. We wanted to just give you some examples of those. So in Ukraine, we're using these longitudinally to measure how provider and consumer level implementation predicts provider performance and retention, or consumer retention and participation. In Myanmar, within the National Institute of Mental Health U19 study that's funding these webinars, we use this instrument to evaluate organizational interventions or implementation strategies. Again, we are using these longitudinally to examine the impact of these organizational implementation strategies. Another way we are using this measure is by administering it with technology and asking respondents to indicate the multiple places of work and multiple roles they may have. One thing we have found in lower and middle income settings is that workers are often connected to multiple organizations. For example, a lay provider may work at a Ministry of Health rural clinic and thus have a, quote, boss there. But their work is largely funded and supervised by an NGO, non-governmental organization. So they have other people that are their, quote, bosses, and this NGO perhaps pays for resources like telephone time or even part of their salary. So when asking about organizational climate, leadership, or even feasibility, respondents are often confused as to who or what setting they should actually be thinking about. With technology, we can create skip patterns like you see here on the screen that would have the respondent answer items multiple ways in relation to their different roles or organizations. So our current work is really focused on ongoing testing and validation in different contexts. We also have incorporated the use of technology in responding to multiple points of reference that respondents may have in low and middle income countries. We're also collaborating with many different researchers, for example, other U19 sites, to use and continually evaluate this measure. So in summary of the webinar today, we come back to the idea that Emily stated earlier, that you can't progress in a field without a solid foundation. As you can see by how long all of this research spans, approximately 6 years for our team, these concepts are complicated to transfer to settings that are truly low resource, where there are no existing mental health services or systems. People should be using, testing, and evaluating implementation measures specifically in low and middle income countries that do not have existing systems to learn more.
That's right, Laura. And although we know that methods to evaluate psychometrics in implementation research can be challenging, given this context, we need to work on more creative methods to do this testing and rigorously evaluate these measures. One of the reasons we think this is so important is because context matters. It matters because it is really hard for people to evaluate one implementation approach versus another if they have no experience with services in the first place. This is what is known as relative advantage.
So Emily and I wanted to acknowledge the many people and organizations that have supported this research and work over the years. We have had many local partners and respondents in all the areas we work, many funders, and many different team partners. Many thanks to all of them. Thank you so much for joining this webinar today. For those of you who have questions, we have a global mental health website that you can go to and find out more information about dissemination and implementation science and research. Here are also some emails for faculty members that have been involved in the development of this measure for implementation science in low and middle income countries. Thank you so much.
Thank you.